Art, I think he has to go. Can you hear me?
Yes.
Yes. Okay. So thank you all for having me this evening. As you all remember, in the years when we do not do the community needs assessment, we do the State of the County Health Report. So thank you all for having me this evening. As you all remember, in the years when we do not do the community needs assessment, around mortality, State of the County Health Report. So thank you all for having me this evening. As you all remember, in the years when we do not do the community needs assessment, around mortality, State of the County. So this is just a quick snapshot of the county. You all are probably very well aware, but very rapidly growing. Rapid growth has been seen for the last several years, and about 50,000 new individuals living in the county since, I believe, 2010, since the last census. And so what that can cause sometimes is strain on resources, strain on service access, and those kind of things, because it's hard to catch up with such a quick growth in our population size. Some of the other data broken down on here looks at county educational attainment, as well as income, so median household income, number of individuals in poverty, and unemployment rate. Next slide. So here's the portion where I'm going to give an update on the priority health issues, or the priority needs assessments from 2020. So the first being housing and homelessness. These are a couple updates across the county. So the first is the Salvation Army has already broken ground and is hopefully nearing their fundraising goal. I think last I saw maybe they had about $1 million left. I could be wrong, but that would take our night shelter. They are the only night shelter in the county, from 28 beds to 62 beds, and from 1 family room to 7 family rooms. With We Build Concord, they just had a name change. It was Concord Family Enrichment Association. It is a nonprofit that the city of Concord started and is led by Dr. Patrick Graham. So in 2020 to 2021, the city of Concord decided to allocate 1 cent of every tax dollar to affordable housing. So they averaged that to be at $1.4 million a year. They've got several projects. They have a 26 unit kind of townhome location going in the Logan community right now, as well as acquiring other parcels to continue to develop more affordable units. In addition to that, looking at a community land trust model as well. Cooperative Christian Ministry, who has been oftentimes a place for mothers and children to seek housing options. They are also having some kind of capital growth through some of the Cabarrus recovery grant money. One is the Housing to Homeless project. So that would serve 40 to 50 families or households, which is 4 times what they're able to serve currently through their current capacity and infrastructure space. And then the other project they're working on is Huddle Housing, which includes kind of a carriage style house, and then kind of all congregated around a central community center. It would look at veterans or individuals that can that need some additional support services, so maybe some of our older adults for that project. So there are lots of big moving projects within the housing space, and so we'll be seeing a lot more coming from those. Next slide. Behavioral health is our second priority issue. I've narrowed this down very briefly to kind of 3 focus areas I believe the county has taken. The first being collaboration. So we do have the Mental Health Advisory Board led by our county commissioners, as well as 3 task forces that are currently focused on data and assessments, justice-involved persons, as well as a trauma-informed communities approach. The next is infrastructure. So the county did award about $14 million of the American Rescue Plan dollars to mental and behavioral health. One grant being about $3.5 million for Atrium Cabarrus to have a behavioral health kind of emergency area within their facility at Atrium Cabarrus. And then the county also has advocated at the state level and received $30 million to support the infrastructure of hopefully 2 behavioral health inpatient facilities that would be located potentially in Kannapolis. The last is servicing and programmatic, and I kind of mentioned that around the funding to support something like CHA is doing. So our expansion of behavioral health services and other providers in the county to be able to provide services at a sliding scale fee or no cost at all, and to use those services to expand to other populations. Next slide. The last priority need is early childhood education and development. This is kind of I call these my family work tree, but Carla Brown at the county, the early childhood coordinator, has really led the effort. So it is a formal county board, the Early Childhood Advisory Board Task Force. There are 4 work groups underneath that focused on different areas of focus around the 0 to 5 population. And then on this slide as well, you can see, and it's in your packet, you can see some of the focus areas. So the healthy work group is infant mortality and well child checks. Learning and Ready to Succeed is, are they on track? Are they on grade level for reading? So they have specific measures that they're looking at to track progress and make recommendations through an action planning process. Next slide. Mortality and morbidity updates. So this is the average age, I guess, citizens live to in Cabarrus County. So the life expectancy. So you can see we are higher than the state, and we are higher than several other counties besides Union and Mecklenburg. I make a note there at the bottom. The State Center for Health Statistics, this is their most recent data that's available. It is from 2019, which we all know very well that is pre-pandemic. So we anticipate that kind of length of life to come down. The CDC estimates anywhere from a year to 2 years, and then for our minority populations, it could be more, realizing that COVID pandemic disproportionately, as well as other health consequences, disproportionately impacts our minority population. Next slide. Mortality and morbidity. So looking at the table there on the left, so this shows the top 10 leading causes of death. The top 10 leading causes of death in yellow in Cabarrus County, so how they rank over time. Diseases of the heart has moved up to number 1 from number 2, and diabetes moved from 8 to 9. You see there Alzheimer's is number 3. And then you can see on the right side, right next to it with North Carolina, is how that ranking compares to where North Carolina has those same causes of death ranked across the state. The chart on the right is leading cause of death by age and has not changed since the last community needs assessment time frame. Again, these do not include COVID in the data. Next slide. Mortality, again, so looking at infant and child death data. So the arrows here tell you if it's red and going up, it means it's gotten worse since the last reporting period. If it's green and going down, it has improved since the last reporting period. These are rates. So they are rate per 1,000 typically. And then the equal sign means it's maintained and stayed the same. Again, this is a comparison of Cabarrus County to North Carolina and how we're doing. I will highlight infant mortality disparity ratio. So that actually, a disparity ratio, I'm sure many of you know, but for the public and those who don't, takes the best performing kind of group. So for infant mortality, our white babies are the most likely to live through 1 year of birth compared to all their other counterparts. The worst performing are African-American babies. And so this disparity ratio shows the disparity. So African-American babies in Cabarrus County are 1.66 times more likely to die before 1 year of age compared to other races, or specifically compared to white babies born in the county. So that is a concern when we look at data and diving deeper into it and understanding what are the gaps in regards to access into education, knowledge, resources, those kind of things across our population. Next slide. So these are just a couple of highlights, and I'm not going to touch on them. You can definitely go back and reference them. But these show where there are disparities related to mortality in the county between different populations in our community. So looking at the African-American women are far more likely to die because of breast cancer compared to their white counterparts, whereas white women are more likely to potentially have a diagnosis. So I would encourage you all to go back and look at this, and I'm happy to share any other additional information that we can about this, because it's just important for us to keep this as a forefront as we look at concerns about health equity and those kind of things in our community. Next slide. Mortality and morbidity, and again, this is kind of long. I'm not going to touch on it. What I'm going to highlight is when you go back and have an opportunity to look, that you understand what this tells us. So the yellow means that, and this is from the Robert Wood Johnson Foundation. They do the county health rankings that come out usually about this time every year. So that tells me I need to check their website tomorrow. But the yellow is saying we are not performing as well as the benchmark counties, so some of the best in the nation, but we are performing better than the state in these categories. The red means we're not performing as good as the state, but we're also not performing as well as the benchmark counties. So you'll see a lot of yellow, many red. I'd like to point out that the red, excessive drinking, alcohol, obesity, smoking, so some lifestyle behavior changes, and I think that's an important focus area as well. Next slide. And then this section looks at the same kind of county health rankings, looking at clinical care access and social and economic factors. So again, those yellow are when we're performing better than the state, but not as well as the benchmark, and the red being that we are performing worse than the state. You'll notice in that physical environment one at the very bottom there, several of those are red. A lot have to do with commuting and air quality. And so many Cabarrus County residents commute out of the county for work, and a lot of people commute into the county for work. So it does impact our ranking within this section. Several years ago, we did rank as 100 out of 100 counties for the Robert Wood Johnson County Health Ranking, which meant in this category area, we were seen as the worst based on these 4 data measures that are there. Next slide. Emerging issues. So equity, I think that continues to be at the forefront. You all signed as a Board of Health in 2020, and late in that year, racism as a public health crisis. So I think that's why we're highlighting some of the data, looking at the disparity. We have to understand that our African-American residents do typically die 2 years earlier than our white, compared to their white counterparts. And so continuing to disaggregate data, CHA has made a big push with our own departments, as well as our partners, to look at data deeper. Zip codes, where do people live? What is their insurance? Their race, their ethnicity, their language, better understanding of our community and how they're impacted differently with health consequences. Substance use and tobacco continue to be an emerging challenge. Prior to COVID, we saw much of our opiate data, and Kristen will share that, going down. That has since come back and gotten worse. Never really went away. As well as tobacco, I think we explore how we can prevent tobacco, especially among our teens, with vaping. During the pandemic, national research found that kids that were experimenting with vapes before pandemic actually stopped using them during COVID because they were using them for social reasons. Those that were already actively using continue to use and used more during the pandemic. So we're going to see some definite negative health consequences there as well. And then I think the big push is moving from COVID to COVID recovery. So recovery and resilience, and having those conversations and moving forward from here. So I think those are our emerging issues and challenges and things that we're going to be working towards in the next year or so. Next slide. This goes into a little bit more about what active response looks like versus resiliency. And so just taking note that in active response, what we're doing as a health department and with our partners, and towards resiliency, so focusing on those high-risk populations, rebuilding and recovering with our community members. So there's some efforts that we're going to be pushing out to the community to get them involved in dialogue and conversations in regards to that. Next slide. New initiatives, community health workers, both CHA and HRAM have really moved forward community health worker related work, and those are boots on the ground people integrated in our community, some with lived experience. They know how to navigate the systems and how to support their peers in their neighborhoods. So that is a huge push within the healthcare space and the public health space to have people in those roles. We've partnered with CCM, the Community Free Clinic, DHS, our own clinics here at CHA and El Puente Hispano, to make sure that we have staff that can support them and be stationed there in the community as well, and not in this office. Next slide. CHA did receive an Office of Rural Health grant, as you know, which allowed us to expand services for some low-income populations. CCM has shared that they've been able to make over 120 referrals to the program, and it allows individuals to get up to $500 worth of dental care. And then if they need other services beyond that, CHA works with them on a slide LC. So connecting people to oral health continues to be an extremely important piece of overall health and well-being. Next slide. Public-private partnership. When we talk about new initiatives, I don't think I've heard the term as many times as I have in the last year, probably, around the importance of this. I think, COVID pushed this forward even quicker, at least for us, I think, in public health, the understanding of the importance of that public-private partnership. And there's some great examples in the early childhood space. The county has partnered with All Saints Episcopal and the Lockhart Development Center, Child Development Center, to have a daycare. The county is a supportive employee of their staff by being able to offset some of those costs. So understanding how do we continue to grow models like that across spaces in our community to address needs. We know that businesses can help with infrastructure and different things like that. So continuing to explore those relationships and make them active in conversation. And next slide. So lifestyle medicine, I know, is Dr. Coyle's baby as we look at all these pieces of health and well-being and go beyond just one aspect of health. So I know there's been partnerships with the North Carolina Research Campus as well as the Cabarrus College of Health Sciences. We're integrating it here in our clinic. We've worked with the Community Free Clinic to integrate it as well, but it's looking at more than just one aspect of health. And Dr. Coyle, I don't know if you want to add anything else to this piece of it before we move on.
No, that's good, Marcella.
Okay. And I think that should be it, and we'll move into some of our data. Oh, and this is just telling you we are now moving paper copy that I used to bring you to an online version. So you will have a link to access this online, and it will not be a hard copy that we kind of distribute any longer.
I do want to jump in here, though, and say that the state has publicly acknowledged Cabarrus Health Alliance, and specifically Marcella, for producing what they call a state-of-the-art needs assessment and report each year, and has highlighted for the other counties that this is the one that should be setting the mark. So I want to thank her and bring to the board's attention what quality work she has been doing for many years. And I believe the state is going to be presenting an award to her and CHA at the public health meeting in April for the top quality work that she is doing on putting together these reports and needs assessments.
Well, on behalf of the board, Marcella, thank you so much. And we all know how great you are, and now it's recognized all over the state. So thank you so much for all your hard work.
Well, thank you. I mean, it truly is a team effort. I end up in everyone's office asking them questions about all these things. And so we're just fortunate to live and work in a space that is collaborative as Cabarrus. And I just get to be the one that hits submit. But thank you all. I appreciate it. The next two slides are just very quickly some data updates. Again, these are online. So the two measures we're focused on for housing from a needs assessment standpoint is those that are considered households so renters and owners that are considered cost burden, which means they're spending more than 30% of their income on mortgage or rent and utilities combined. So you can see that that's gone down over time. But it continues to be a challenge. Again, this data is from 2019. That is the most recent we have at this point. So as soon as it's updated, it gets put into our system, so it's publicly available. The other is number of individuals that are considered homeless. And so that top blue line there is the number of children that Cabarrus County and Kannapolis City Schools document as homeless each school year. The bottom line is the point in time count, which is a data measure that comes, it's done last Wednesday in January, and they physically count the number of homeless individuals. The reason this number has gone down is because they changed what they asked providers to do this last year. They asked them not to go out and count individuals in tent communities and in other areas. They asked that they only count available beds. So it's down to 78, but that is just because those are the number of beds that we have available for the homeless or those in housing need. It's not counting the 14 to 15 tent communities that our law enforcement share that we have out there, and 15 to 20 people at each tent community. Next slide. And then mental and behavioral health scorecard, we measure several different things on here. The two that I'm going to highlight are the EMS calls for service. That's the bottom one there. So for psychiatric patients or psychiatric episodes, and then ED admissions at Atrium Health for psychiatric patients there. During the pandemic, you can see that we did have a dip from 2019 to 2020. That was not due to not a need of behavioral health services, but more of concern of going to the hospital during the pandemic and contracting COVID while there. So we do expect that number sadly to go up and probably go up quite a bit more. But again, these are measures that we're looking at as a community and as partners so that it can tell us how we're doing, or we can identify gaps and challenges. And I'm going to ask Kristen to share. The next couple of slides are around her substance use scorecard update as well.
Marcella?
Yes.
Marcella, it's Mark. Are our EMS folks trained in the skills necessary to handle behavioral and mental health issues?
Yeah, so we actually had that panel discussion today. So EMS is what's called crisis intervention team trained, and so are our law enforcement. They participate, law enforcement participates in 40 hours of training. EMS requires all of their drivers to be CIT trained so that they can handle these situations while on scene. And Justin Bryant actually shared this morning, that their big vision goal would be that they could be using their community paramedic program, which is not an emergent issue type program where they are responding to people at their home, not in crisis, but doing follow-up after discharge and those kind of things, that they would move towards a model that those would also follow up with mental and behavioral health patients. So they are trained, they are exploring ways to do more than what they're doing currently. The challenge there is infrastructure on where to take someone in a behavioral health crisis that is not our emergency department.
Hey, Marcella, may I ask you a question?
Yes, absolutely.
This is Daryl Adams, and this was a couple slides back. You had some data that looked at the people living in poverty, and I think you kind of addressed this somewhat. Do you have that data broken down by zip code by any chance?
The percent living in poverty from the census?
Yes.
Yeah, I could pull it for you. Yep.
If you don't mind, I'd love to see that.
Absolutely.
Great, thank you.
Oh, no problem. And I know I talk very fast, and I know you all have very short board meetings, so I probably didn't leave any opportunity for a question earlier. Any other questions before Kristen shares some of her slides? All right, Ms. Klingler-Smith.
Hi, everybody. I hope you all are having a good evening. I'm going to go through quickly our substance use scorecard that's going to touch on prevention and harm reduction. I've really enjoyed adopting the results-based accountability model, and I think these scorecards are definitely going to be helpful as we proceed into the future. And it's something that in our programs, we definitely want to make sure that we're keeping relevant, up-to-date data. So the first performance measure that we have for prevention is % of students who report giving someone money to buy alcohol for them. And you can see over the years that we have decreased in that element. 2018 and 2020, there was not a survey completed during that time, but we do have the 2021 data, and you can see that from 2019 to 2021, less students are reporting that they have given somebody money to purchase alcohol for them. I wish that meant that they weren't drinking. They're just means they didn't give anybody money. Another performance measure is % of students who agree or strongly agree that peers misuse medications to cope with problems at home. And I don't think it's any surprise that in 2021, when we completed the survey, that we see that there's an increase. I think whether we're looking at qualitative or quantitative data, this is going to be something over the next few years that we're going to continue to see, whether because of COVID, just being the stresses of being a student, what have you. But that's kind of the story behind the curve when you're thinking of, or potential story behind the curve when you're thinking about why students, or it's perceived that students misuse prescription medications. And then the next performance measure that we have for prevention is % of students ages 13 to 18 with access to prescription medications stored in an unlocked cabinet or drawer in the home. And when we conducted the last survey, we saw that there was an increase. And, when Marcella and I were talking about what could be the reason that this is happening, one thing that we thought about was students being home for such a long period of time, seeing more of the behaviors of their parents, maybe snooping around a little bit more could potentially be the reason that we've seen an increase. And so we'll definitely want to make sure that we're pushing out information and messaging to remind people to make sure they're locking up their medications and storing them properly, disposing of them properly, and not sharing. And as we move into our harm reduction scorecard, we have the number of unique individuals served by the syringe service program in the last year. 2020 was an extremely busy year. I think there was a lot of panic and a lot of different elements that contributed to us seeing increased unique individuals. But 2021, we have seen that go down just a little bit. Number of naloxone kits distributed by the syringe service program in the last year. In 2021, we were able to distribute 1,800 naloxone kits. And then 2020, we gave out a ton of kits. But the next indicator, or the next performance measure that I'm going to highlight, I think is pretty interesting. So in 2020, you can see that for number of reported reversals, so that's somebody who said that they used a naloxone kit that they received from us or from some type of community-based program. You can see that in 2020, there were less reports of reversals, but we saw more people. And then in 2021, It was astronomical how many reports we were receiving from individuals. And I think when we're looking at this, it's really highlighting the benefit of peer-to-peer education and naloxone access out in the community. When an individual comes in to get a naloxone kit, they're not just getting the kit, they're getting the education component as well. So that not only do they know how to properly use it, but they can educate someone else on how to properly use it in the event that there's an overdose in the space that they're at. And I believe that concludes the substance use scorecard.
Yes, thank you, Kristen. And all the scorecards are online. So if you want to look at comparisons, we also track data for overdoses in the county. So you can see how does our 2021 number of reported reversals of the kit compared to the total number of overdoses in the county, because then you can start to kind of see maybe how many didn't call 911 or use other services. And then the last update we have for me and my team is the marketing just update. So some efforts there. We don't have a scorecard at this time, but it's something we're working on. You can obviously assume that with COVID, we had a lot more followers join us on Facebook, which was great because we're able to share other public health education and information with them. So in the last year, CHA's Facebook page, our main one, reached 580,000 people and 7,500 total followers. Pre-COVID, we were about less than 2,000 people that liked us on Facebook or followed us on Facebook. We do have a Spanish page. It's fully in Spanish. So that reach was about 70,000 people and about 2,600 followers to date. Our Google review score, if you remember when Tracy came to you all last year, was to get it above 4. So we are at 4.1. We have over 20,000 clicks from Google onto the CHA website. And then we're also working to make sure that our website is linked best with search terms and things like that. We're also going to start working on how to have more patients within our other services also provide feedback, whether it be via Google or other platforms, to share their experience, because so many have had great things to say, and we want to make sure that's captured as well. And then the last goal that we focused on is a training for staff. Tracy's currently working with our HR department to do a new staff training and an orientation as we have new staff coming on, just following policies, procedures, expectations around what your email signature should look like, a PowerPoint template, all of those things. So we will be doing that as well. And then on the horizon, we are looking to have some more video, whether they be short or longer, just educating people on the services. Recently, Dr. Still, our dentist, did one with one of her pediatric patients, and it was just a great personal touch to what we do and what our staff do here at CHA, taking us out of this building, looking at the true services and the impact that we have on people. So we're going to try and do a little bit more of that and personalize us as an organization. And I think that is all that I have, as well as Kristen. Any last remaining questions from you all? All right. Well, that is all I have for my piece.
Well, Marcella, I just wanted to add a couple things. Excellent report. Thank you very much. I know that when you were talking earlier, you mentioned it at one point, the fact that the emergency department was not the appropriate place to take some of these patients. And I just wanted to make sure that the entire board is aware of the activities that we're involved in now, and you had mentioned it earlier, but Marcella was along with myself and several county staff and Sonia that visited behavioral health facilities in Guilford County earlier this week. I get my weeks mixed up, but it's been within the last several days, 5 to 10 days. But to try to provide that facility to have that appropriate place to take those people. So we're working really hard on that, and the cooperation between the Health Alliance and Atrium and the County Commission is that collaboration is critical in what we're trying to do, and we keep getting a little bit closer. So I'm really enthusiastic about it.
Yes, thank you, Steve. The county has been a huge support and advocate around the behavioral health space, and I don't know that we would have as bright of a future if we didn't have that type of support from you all. So thank you.
Marcella, I just wanted to say I'm glad you speak so fast, because you got such a wide range of activity that you got going on here. We would be here all night if you couldn't speak as fast as you do.
You're the only one that will say that you like that I speak fastly, but I appreciate it and glad I could cover it all.
Thank you, Marcella. And now we're moving on to the health director's report.
Okay. We have the report in your packet, but I will just highlight some of the most important things that we have done over the past 2 months. On the first page of your report, you see our support services accomplishments, and you can see that HR, finance, and IT have been very busy. We are going to start phase 2 of our salary study. Hopefully you remember that we did phase 1 last year, looking specifically at positions and salaries that might be too low and getting those corrected. Phase 2 will include looking at our job classes and our grade realignment, trying to consolidate some of that. We also completed our equity organizational assessment as required by the one of our state grants, and hopefully by our May meeting we'll be able to talk about some of the results from that and the action plan. We are actively in budget cycle time, and Sue has been working with all the department leads putting together our FY23 budget. We had a preliminary meeting with the county for the county part of the budget last week, and that went well. We've submitted 6 grants this past month, so we continue to be very active in seeking additional grant funding. And I'll point out that our environmental health department, really proud of the work they're doing under Crystal Swinger's leadership. And they submitted for 3 grants from the FDA and have brought in over $114,000 to improve our conformance with the voluntary national retail food regularity program. So really excited to see the environmental health team looking for grants and finding additional ways to make our program even better. IT has been active deploying new software, phone technology for our school health team, and also improving the phone system and disaster recovery across the whole agency with the technology. So big thanks to them. Under our clinical services, we are dealing with Medicaid transformation and trying to work out the kinks to assure all the revenues that we are deserving of receiving are coming through. We have expanded our Cabarrus Youth Development Center and taken on the responsibility of caring for the long-term detention youth in addition to the current youth that we are caring for. So that has been some additional responsibility. Again, juvenile justice saw the model that we use at CHA for providing that care as top-notch and asked us to take on some additional folks when a few other sites had declined serving additional folks. And we're also taking a look at how to integrate our COVID core team functions in with communicable disease in general, as we are hopefully moving from program services to a more resiliency model. Dental health has been busy. We've hired a new dentist, and we've gotten back to doing the kindergarten screenings and are going to start and are taking our mobile units out now in March. You heard previously from Sue that had been on hold, but we are getting that community program back up and running, which will be incredibly helpful, as we've noted that decay rates in our kindergarten kids has increased through the pandemic, as sadly a lot of people put off accessing care. In school health, we have brought on 4 new nurses within the past month. I think you're all aware that this is an area where retention and recruitment are very difficult to get public health nurses for school health. So we right now only have 1 position open. We're hoping to get that filled very soon. They are all using a new medical EMR system called SNAP that will hopefully allow us to do more effective public health data collection to monitor the health of our kids. Under our Healthy Living program, you will notice in Marcella's report, she talked about how some of those healthy living metrics are we need to do some work in, like our smoking rate, our obesity rate, our binge drinking, and so in some discussions with the Cabarrus Wellness Coalition, we've decided that that's going to move under CHA, since we are putting such a priority on focusing on healthy living metrics. And so we will be providing the oversight for that county-wide work going forward. We also are working with our worksite wellness program to expand some of our programs to the school district in general, and are piloting right now at one elementary school with the intention of going more district-wide in the future. Under Healthy Cabarrus, the State of the County Health Report that you just received tonight, Marcella has also been presenting to other groups as we go around, updating everybody on our priority areas and the progress that we are making on them. And Commissioner Morris just emphasized to all of you that there was a site visit to the Guilford County Behavioral Health Facility on March 7th for us to see the excellent model they've developed, in hopes of bringing that model here with some of the funding that's been received to start to build some behavioral health facilities. With substance use, one of the things that we have done is partnered with the community paramedics to come in once a month and provide services on Wednesdays. I believe Kristen alluded to that too. Just want to point that out as a wonderful partnership where we are looking to bring services to individuals who may really struggle to receive them otherwise. We also receive funding to cover our whole region with a hepatitis C. It's called Bridge Counselor. It's essentially a care management program to help people who are diagnosed with Hep C get connected to the services and the programs that will help them get the disease treated and avoid any of the chronic problems that can arise. Our community health worker program that was mentioned previously, our workers are currently going through the certification process and will receive that on April 4th. We're very excited about this program to focus on social determinants of health and bringing access to programs and services to the most needy people in our county. And I think we have developed, again, a program that is going to be in the future highlighted as a model program as we look to help our county. And so really excited that our community health workers are working through the certification process. Under performance and quality improvement, our team has designed a number of trainings that all of our staff are now going to be taking over the next few months to get even better with data. As you know, data has been one of our priority focus areas in the 2 years I've been here, and we think our report cards and scorecards are getting better and more impactful as more and more of our staff get more comfortable with the whole RBA process and data metrics in general. Just two things to point out under Board of Health activities to have at your attention. Again, NALBOA, which is the National Association of Local Boards of Health, is hosting a virtual spring symposium on April 28th from 2 to 5. We have signed up for a link to link into that in the boardroom on that day. A couple of you have expressed interest in attending. If any more would like to participate, you are welcome to join us. In addition, Merle Green, she is the executive director of the Association of North Carolina Boards of Health, and she spoke to the health directors at our last state meetings in February and expressed a desire for the state association to get more closely linked with local boards of health. She had several recommendations, including one to have them join in on one of our monthly meetings. So I just wanted to share that, see what you all thought if we asked her to join in maybe at May's meeting and give a little update on the state association and just have an opportunity for us to talk with her for a little bit. Everybody think that's a pretty good idea?
That would be great.
Okay.
Agree. Yep, that'd be great.
Okay. And then just a couple of sort of national, state, local legislative updates. Kristen Klingel-Smith and I joined a number of other statewide community members to speak to Representative Kristen Baker on March 2nd about substance use disorder and what is considered evidence-based best practice. Kristen did a fabulous job. I don't know if she's still on the call, but she was, it seemed like Representative Baker really appreciated Kristen's presentation because she had a lot of data, a lot of examples to use that really helped Representative Baker understand, what would be good sound legislation and what might not be some best strategies. So hopefully that we help to educate her and can see some really great work coming out of those efforts. Several of our staff participated in a forum at NCRC in February that state legislators and community leaders were present at, highlighting all the great work of the campus. And then just wanted to bring to your attention that the State Department of Health and Human Services has really been focused on a number of priorities around foundational public health focus areas, but they have really highlighted public health workforce development and recruitment as an area that is so important statewide, and they're looking for opportunities and funding to develop statewide efforts, and are also encouraging all of us at the local and regional level to be engaged in that too. And we are very focused here locally on public health nurses and environmental health specialists, which are two areas in the public health field that are particularly difficult to recruit for. So we're excited that things that we've already identified regionally as issues to work on with some ARPA funding that we received, that the state is also seeing them as top priorities and looking for opportunities to work on that also. The last thing I want to bring up, which isn't in the report, but thought this is a good time to sort of do a quick check-in, is now that we are in the green for our COVID, as you will see from Erin's presentation in a few minutes, we would like to return to in-person meetings in May. Want to just do a quick check-in with each of you that you would be okay with that. And then start holding those meetings as we used to down in the community room, starting with the May meeting. So do we want to do a quick roll call, or do we just want, everybody want to just give a yay or nay as to returning to in-person meetings?
Roll call. Okay, Cecilia Flez, are you in favor?
Yes, yes.
Kim Daylor.
Yes.
Asha Rodriguez.
Yes.
Mark Spitzer.
Yes, if you're serving dinner.
Okay. Daryl Adams.
Yes.
Dan Hagler.
He may not be on anymore. I don't see him over here on the participation.
And Steve Morris.
Yes.
Okay. Okay, we might have lost Dan. Okay. All right, and then so we will return to in-person meetings in May. Yay! Okay, next is the consent agenda. Do I need a motion to move into that, or just for the Shasta read this?
Sue will talk
Sue's gonna
briefly,
talk,
and then we'll need a
we're
motion
gonna-
to approve it. Yeah.
Sue, you're up.
Yes, this evening's board budget revision requests. There are 7 budget revision requests. 2 of the largest ones are the county ARPA funds for our information technology department. And then the school health ELC, we are reducing that budget by $2 million. At the beginning of the year, we got a $4 million agreement addenda, and we are only going to need a little over $2 million this year. So we went ahead and reduced that one. Does the board have any questions regarding the budget revisions?
Nope.
Okay, being no questions, I need a motion to adopt the consent agenda.
So moved.
Can I have a second?
Second.
I've got Daryl Adams. Okay. And so Cecilia Ples,
Aye.
Kim Daylor,
Aye.
Asha Rodriguez,
Aye.
Mark Spitzer,
Aye.
Daryl Adams,
Aye.
Dan Hagler, Steve Morris,
Aye.
Okay, thank you very much. So motion carries. Next, we have the business agenda, and we have the financial policies.
So there are 4 financial policies. We bring policies to you every year to make sure that you have a chance to review them. The reserve policy, the dental clinic fee policy, the dental clinic debt management policy. Those 3 have not had any changes this year. I am bringing to you a new policy for the community-based behavioral health, their eligibility policy and fee waiver form. As we get this clinic up and running, I'm sure we will be bringing you more, but this is the first policy for you to review for that particular program. Are there any questions?
This is Kim Daylor. So under the dental, and I don't remember which policy it was, but there were a lot of definitions or metrics, I should say, for determining, and I wish I could remember where it is. Let's see where it is. Anyway, when you have definitions of when you would maybe waive a debt or how, there it is. Go up. I'm so sorry. I didn't write it down. Anyway, I was wondering when you have definitions, where those are. Okay.
Can you?
Right there. Yes, stay. 2.3.
2.3.
Majority of group located in a food desert, District 1. So when you are defining something as a food desert, when you're defining residential mobility, are those understood definitions somewhere in the Health Alliance, or do they need to be within these different policies or these different programs?
We can add them within the policies and the programs. The food desert, I believe Marcella's group identifies those food deserts and
USDA.
USCA. Okay, thank you.
Yeah.
Yeah, so do we need to have specific definitions, or do we need to say as defined by the USDA, or is that not necessary and I'm just overthinking these things?
I can definitely say add to the policy as defined. Yes.
Okay, just something that would, yeah, I just think more specific there. I also said has moved X amount of times in the last year. What is X amount of times? Is there a definition for what indicates somebody is in trouble?
Marcella, are you aware of what makes someone considered, it's resident and stable? So if someone doesn't have stable housing, but I will get with Dr. Steele and get that number of times that they use at the front desk whenever they are talking to these patients for eligibility. So I can remove this dental clinic fee policy and bring it, this particular one, back next month with these definitions clearly defined.
I think
And
so.
I'm happy to provide any support as well. Seeing that it says the mobile dental unit and that unit's to go into schools, I would think that maybe has to do something with McKinney-Vento kids that have been classified as possibly homeless. So there may be ways for us to put more parameters on this, and just let me know how I can support that.
Okay, thank you. I will work with Dr. Steele and Marcella to make sure that for 2.3, these are clearly defined.
Thank you, Sue. If you'll just bring that one back next time. So I need a motion to approve the other policies excluding the dental policy.
Motion to approve.
Okay, and can I get a second?
Second.
Second. I have a motion by Kim and a second by Mark Spitzer. So all approving: Cecilia Ples,
Aye.
Kim Daylor,
Aye.
Asha Rodriguez,
Aye.
Mark Spitzer.
Aye.
I got Asha and then Mark
Aye.
Spitzer.
Aye.
Aye. Daryl Adams
Aye.
and Steve Morris. Dan Hagler.
I'm
Okay.
back, but I don't, that's a yes. I don't know what I'm voting on.
Okay. You're fine. Okay.
Switch to a different computer.
Okay, great. Unanimous. Okay. All right. Thank you, everyone, on that. And now we're moving to the COVID-19 update. I'm actually excited to hear for once.
Give me
Been a long
just a
time
moment while I
since
switch our screen.
Thank you, Miss Erin.
Right. Okay. Can you see that slide that is on your screen? Excellent.
Yes.
All right. Well, thanks. Yes, it's exciting to be able to add a subtitle that says Journey from Response to Recovery. But before I get started, please let me make it abundantly clear that we are not out of this pandemic. But it is important that we begin talking proactively about what steps we need to take so that we are successful in our recovery efforts. So let's quickly, we're not going to spend a lot of time on data tonight. We're going to spend more time about kind of reviewing some fundamentals, but I did want to bring to you some of this good news. Most importantly, I want to share with you in that third row, all the way to the end where it says 52, that represents 52 new cases in the past week. So on Mondays, we are still meeting with our local leaders. And so this was our slide for yesterday. Unfortunately, we continue to see folks pass away from COVID. And so as much as we are looking forward to recovery, we have to remember that there are still people who are not able to successfully beat and fight COVID. So our deaths are at 465 as of yesterday. Our percent positive is down to 3.3. That's really excellent. I will say we anticipate this being a metric that really becomes less utilized as more people have at-home tests. So at-home tests are not reported to us. An occasional person will call and report an at-home test, but that is not the norm, and that's certainly not the expectation. So we are happy to see that 3.3, but we are looking to see how we will be moving this metric forward in the future. And I will fix that 2022. That year is off there. Cabarrus residents hospitalized 7, total hospitalizations 32, and then if you'll look down the active, we're at 190. So I'll also ask you to look back to February 14th. The number of active cases was over 2,000. So look at how quickly we dropped from 2,400 active cases to under 200 in that month's time. So really a positive news all around. This is our newest report that just came in today, this afternoon, so it's hot off the press. This shows our epi curve, if you will, for the growth of cases all the way back to the beginning of the pandemic. So here again, you're seeing really significant drops from this Omicron surge. And so we are certainly feeling it here at Cabarrus Health Alliance. Our partners are feeling it, those that we have checked in with. So that is, that's good news. again, just graphically, our percent positive here. One of the things we continue to look at is, are tests widely available? Are there any access issues? So we had over 2,300 confirmed lab tests completed last week. So there are very few access issues for testing right now. This just looks at our active cases. This was pulled today for the last 14 days. There were points in time where we would have been happy seeing 167 cases for the day, let alone the last 14 days.
Aaron,
Vaccine, yes, sir.
Aaron, is this information also somewhat suspect to the fact that folks are having mild cases and perhaps not reporting them? I'm not sure what the reporting mechanism is here, but is that also potentially the case why we're seeing the large drop-off?
Absolutely. So the more folks that are vaccinated, so I'll go ahead and flip to that next screen. Symptoms are milder. People with mild symptoms may be choosing not to get tested, certainly not to be tested in a physician's office or a pharmacy where they are legally required to report that to us. So that certainly could be a part of it. Dr. Coyle?
Mark, the other thing that, with Omicron, and this was seen across the world, it had a massively quick uptick, and now it is having a very quick drop off. So it's sort of been the experience with Omicron, not just across the country, but even, in other countries too. You will notice on Aaron's one slide there, the number of infections was 3 times as high at its peak as any other time in the pandemic. So we had more cases than ever very quickly, but also the quick downslope, which is what we kept hanging on to as we were getting so many thousands of cases a week.
So in terms of vaccine tracking, we sat at 58% of total population with one dose for a long time. So we were happy in the last week to see that tick up to 59%. We would really like to still meet that 80% goal that we set a long time ago. But the reality is that that's not happening quickly. But some of the recovery work that our teams will begin doing will be very targeted vaccine outreach. But we are a leader in terms of vaccine in our region, shown here. So I wanted to bring you up to date on some evolving community protocol and policy changes that have really impacted the types of education we provide to the community, but also our operations. So I'm going to quickly move through these. I hope that you have seen by now the CDC Community Levels. This is the new mechanism by which the CDC is educating individuals on the mitigation strategies that they may want to consider as they are moving about. So this top map shows the United States, where you can see the largest proportion of the United States is in that green or that low category. The bottom map is North Carolina, where most of North Carolina is also in low. So to the right, what I've snipped for you here is, what does low mean? And this is individual strategy. So low means an individual should stay up to date with COVID-19 vaccines. So up to date, that up to date term means including boosters if you're eligible, and then getting tested if you have symptoms. If we were to be in that yellow category, which when this was first introduced, we were we were actually in the high and very quickly became yellow and then green. But in medium, if you're at high risk for severe illness, you should talk with your healthcare provider to have a plan about what to do if you become COVID positive. You should consider wearing a mask. You should stay up to date with vaccines and then get tested. And then in high, that's really recommended that everyone wear a mask indoors, staying up to date, getting tested, and then of course if you're at risk, using additional precautions. So you'll see us begin pushing this much more in the coming weeks so that our community is familiar with where we are. Additionally, both the Strong Schools and the Child Care Strong toolkits were updated. The most aggressive updates that we have seen throughout the pandemic, essentially mask wearing, universal mask wearing is no longer recommended. And then there are additional criteria by which close contacts are not necessarily required to be quarantined. So I will provide those links to you, but this had a major impact on student exclusions, both at the K-12 area and then in child care centers as well. And our child care centers have just been really hit hard, not only with staffing issues, but then children needing to stay out for long periods of time. So we hope that businesses are also seeing some relief with their staff not needing to be out with their children who have to be excluded. Of course, anyone who is COVID positive or symptomatic, there are no changes there. So we're talking about symptomatic or close contacts here. In terms of internally, our case investigation prioritization has also changed. So the state has given more direct guidance on who needs that phone call for case investigation. So you can see here it's broken into 4 priority groups. Priority 1 would be cases that are linked to clusters or outbreaks, and then cases reported as living in congregate or healthcare settings. So those are our most high-risk individuals and most high risk for spreading COVID to someone else. And then it goes downward. You can see priority 3 and 4 both have the asterisk, and that means that notification phone calls may be done, but it's more in terms of asking them if they need resources. So connecting people to resources, and we're not talking about just healthcare resources. We're talking about those social determinants of health that we've really been working hard on, and our community health workers are just doing an amazing job at that at the moment. Also internally for our staff at CHA, we've also changed our protocols as the data has improved. So we have also put into place a color spectrum, and I'm pleased to say that as of yesterday, our staff are now following that green area, which is limited restrictions. We're so excited that our patients are able to bring guests with them again. That was so hard for our maternity patients to be limited to who they could bring to their appointments with them. So there are no visitor restrictions anymore. Because we are a healthcare entity, there are certain CDC rules that we have to continue to follow regarding masking. So masks should be worn by all guests and patients in common areas, but then those are relaxed in other areas. So again, you've got this in your packet. We will continue to, this will be fluid as we need to change it, but our staff have been really appreciative of the updates recently. Oh, the title didn't show on here. So sorry, I'm not sure why the title's not showing, but wanted to give you just a quick update on employee vaccination. So here you can see our employees that are boosted and then vaccinated, not eligible for booster. And then we've got it broken down by vaccinated, but not yet boosted. That's that gray area. And then unvaccinated in the yellow. So I apologize. I'm not sure why it's not sharing in presentation mode. So we continue to encourage employees to get vaccinated, get boosted, and we're really working hard to understand why employees may be choosing not to be boosted if they're eligible, but just have not yet. You know, in the spirit of full transparency, want to share with you that we had our fair share of problems over the past couple of months with positive cases and CHA employees. So here you can see we had in January a lot of positive cases in our employees, and so if we were to overlay this with the epi curve for the state, it follows pretty closely what we saw in our own employee population. I'm happy to report that the last 3 weeks, I'm going to knock on wood here, that we've had 0 cases, and so we're pleased with that. And then also, interestingly enough, and again in the spirit of full transparency, you know, looking into seeing for our staff who were COVID positive, what was their vaccination status, so we can really fully understand the impact. So 30% of those individuals were boosted, so meaning fully up to date on their vaccines. 23% were vaccinated, so they may have had both their doses of Pfizer, but not yet eligible for a booster. 24% were overdue for their booster, and then that last person, that gold area, was unvaccinated. So that really brings me to what next? So you say, Aaron, you're telling me where we are with COVID, and it sounds like things are moving in the right direction. So what's next? So we're really going to be moving forward aggressively with recovery and resiliency conversations. So looking at, we're in that response phase now, that green bubble moving into recovery, that then leads us to mitigation and prevention of future occurrences and being prepared. So one of my favorite epidemiologists that I've been following for many, many months now, her name is Caitlin Jetta-Talina. And she has just done an amazing job of translating really difficult concepts into layman's terms. And so if you would like her information to follow her, she puts out multiple newsletters a month. She does a great job. But I loved this image that she included in her last newsletter, and it's sourced to Victor Singh here. But it shows that, where we are in terms of the response of a pandemic now does not mean that when that wave is over, our work is done. So the quote reads, "The health footprint of any pandemic typically extends for decades after immediate impact." So you can see here where they've got the first wave being immediate mortality and morbidity, the second wave being impact of resource restrictions on non-COVID conditions, the impact of interrupted care on chronic conditions, and then that fourth wave being trauma, mental illness, economic injury, and burnout. So I am so thankful to live and work in a community that is having very serious conversations about behavioral health. I feel blessed to work for an organization that has taken the steps to increase our behavioral health offerings for our community, because I truly believe that that is what we're all going to have to work towards next. But first, I wanted us to go back to just remind ourselves of the foundations of who we are as an organization, because I want us to go into this recovery phase just remembering kind of who we are and why we are, because we have newer board members, and what do they call legislators? Freshman legislators, some newer board members who have been through orientation, but just wanted to spend this time, a few minutes talking through, and a reminder of who we are to hopefully also give us some ideas of how we move into recovery as an entire public health agency, not just the health department that made us do these COVID things. So CHA is the local health department in Cabarrus County. Your legal name is the Public Health Authority of Cabarrus County, Inc. Our mission is the same mission statement that it was in day one when we became CHA in 1997, achieving the highest level of individual and community health through collaborative action. So that is one of our amazing dental health hygienists on the bottom left doing a table at, I believe that looks like Beverly Hills Elementary School. And then on the right, that's Sandra Torres at one of our cooking classes in the kitchen. So why did we become a public health authority? If there's any question I get asked most, this may be one of them. So in the mid-90s, our commissioners, our board members, our health director recognized that there were really decreasing funds and support for public health, and we needed to look at what we could do to make sure we maintained our viability. So a study was commissioned. UNC Chapel Hill was a part of that. A broad cross-section of individuals were brought together to study if this was something we should go towards, and it was favorable. In July, we will celebrate our 25th birthday as Cabarrus Health Alliance, as a public health authority. The Cabarrus Health Alliance was created in 1997 under General Statute 131E as a hospital authority. And you may say, Aaron, oops, that's a typo. It's not. We're a hospital authority. I assure people all the time that we are not going to be applying for certificates of needs for beds. Under the statute, the hospital authority is an autonomous governmental entity governed by a board of commissioners or a board of health. So we're still responsible for all the traditional public health services in Cabarrus County. And some people would say, but why? Why in the world did you do that? Why was it needed? So I want to show you, this is what has happened with our funding for public health since 1998. So we could do a little digging and show you pre-97. that it was flat or decreasing. But I wanted to show you the excellent work that your public health teams have done in the last 24 years to make sure that public health resources came into Cabarrus County to support our community. So you can see that upward trajectory for funding. This is the ending balance since 1998. Our funding diversification, that was a key goal, was be able to diversify our funding. You know, that old adage, not all eggs in one basket. Well, here we go. This shows you how our funding is diversified. And this is our 2021 fiscal year actuals. Of course, we're not done with fiscal year 2022, but you can see the makeup of how our services are provided by financial type. Also, our innovative and responsive grant writing. Most of you have been a part of grant writing and know that you're not always given the benefit of a 90 or a 120-day lead time. A lot of times you have a 14-day lead time. So the ability to focus in on those efforts quickly, to turn around quickly, and to get those submitted has been an absolute game changer for us. And I think this graph clearly illustrates how your structure supports that. Sarah is on the call with us and does an amazing job, as noted in Dr. Coyle's Board of Health report, director report this month. So just quickly as a reminder for you, a comparison of powers by the type of boards that exist in public health across the state. So we have a 9-member board, and you can see the types here: a Cabarrus County Commissioner, a practicing physician, dentist, infectious disease, 3 public members. And then on the bottom, you can see the types of things that you are able to do. Again, being nimble, being flexible, and being able to respond quickly is part of what makes you unique and makes the structure work. And then, of course, you know, your role as a board is to assess, assure, and improve the health of the people in Cabarrus County. Honestly, 2 through 7 could be encapsulated in number 1. And that's the most important thing that you, as a 9-member board, 8 members right now, the 9th coming on board in May, do, is to make sure that we are providing services that need to be provided. And you know what? And I said this to our Leadership Cabarrus class earlier, we don't always need to be the provider of that service. If there's another group in Cabarrus County that can do that and maybe even do it better than us, we want to support them. We want them to be able to do it. But if there's no one else that can do something and we are asked to take that and run with it, we absolutely will. As a board, you must review financial reports. Sue and her team do a great job putting those together and bringing those to you at your board meetings, discussing service costs and approving fees and final budget, and then advocating for funders for wide support for public health. It's great timing. We're talking about this today. You've just heard the State of the County's health report. So providing input and reviewing community health improvement plans, being part of that process, and educating and advocating with community leaders about health issues, which, you know, I could give example of the things that this board has done to do just that. And then ultimately, you're responsible for hiring a qualified health director when that position becomes vacant and reviewing with them performance year over year. So here we are. I am so excited about the changes that we have made at CHA over the last 2 years. This is our current organization structure, how we do what we do, with a real focus on foundational capabilities and foundational programs. CHA is leading the way in how we are organizing this work because we've been doing this now for a year. We've been organizing ourselves to get here. Just this week, yesterday actually, FAB, which is the National Accreditation Board, put out this model showing that this is the way public health entities should be moving. Folks, we are there. We are there, and it is working. And I think if you talk to most any leadership team member, they would tell you how excited they are about the direction we are going. So looking at those foundational areas: communicable disease control, chronic disease and injury, environmental health, maternal, child, and family health, and access to linkage with care. We are doing tremendous things in all of those spaces. But what I'm most excited about are those foundational capabilities. How do we integrate assessment and surveillance into those 5 bubbles up top? And we are doing those things. Same with community partnership development. Marcella does a wonderful job working with all of our programs with developing partners through her existing partnership. So I could talk for a long time on this, and I won't tonight, but it's really an exciting time coming out of a pandemic into recovery mode using this model. So just as a reminder, this is where we are for this fiscal year. Of course, all of our activity is driven by our needs assessment, our largest umbrella in the community health plans. CHA noted that the data showed that healthy living was really an issue in Cabarrus County, and so that is one of our CHA health priorities. And then on the right in the blue box, you see we're also guided by a strategic plan that many of you were involved in, strategic priorities, foundational capabilities we just talked about, and then mandated services. So looking into next year, and this is certainly not final, but we will continue talking through these things. But you're going to see recovery and resiliency as another priority area that we'll be focusing on. And we'll be asking you to come alongside us and help to lead those conversations and those efforts. I already put a plug in with our Leadership Cabarrus class today. So we want folks who were most impacted through the pandemic to be involved. We want individuals who say, you know what, I really wasn't impacted by the pandemic. We want all walks of life alongside of us to help us understand how we move forward. So what do we need from you? Last slide, I promise. So what do we need from you? Continued support for all public health services, advocacy for sufficient public health funds at the federal, state, and local level. You guys do an amazing job at that already. We need assistance educating the community about public health in general and Cabarrus Health Alliance. Over the last 2 years, it's really the first time many people have become more acutely aware of public health and what public health is charged to do. And then from you, we need that reaffirmed expectation that you want us to be the best. You want us to be a leader. You want us to be a leader not only in the state, but the nation at what we do, by being innovative, progressive, and cutting edge. And so I'm excited about this new recovery and resiliency efforts, because I think it's really going to provide us with a springboard into kind of the next phase of public health and where we need to go for our community. And I think we have the best community to do just that. So any questions about COVID? Any questions about kind of that CHA 101 recap?
Erin, are those included in the slides in the, were your slides included in the packet?
They were not, because I always wait to update the COVID data as soon as before the meeting as possible. So it's most recent, but I will, I'll get these to Rakisha and we'll get these out to you after I fix those labels on those pie charts. To make sure that you've got those.
Yeah, please send that out to everybody.
Yes, ma'am.
Any questions for Erin?
That was a great overview, Erin.
Thank you.
And I just want to say thank you for walking through the structure. I think sometimes we don't always understand that the decisions or the structure form follows function. And so I think what you all have set up have allowed the county to take advantage of so many resources, but have also created speed to market opportunities for us as a county. So I want to thank you guys for that and for walking us through that. I hope that people walk away with a solid understanding now of how we've been able to do the things we've done. And I say we as in the Cabarrus Health Alliance over the last couple of years. So thank you for walking us through that. And that was really powerful.
Thank you.
Asha, I agree with that. Thank you, Erin, for doing this. I think that we need to continue to, particularly as a new board, in many respects, with the exception of Steve, we need to continue to really understand our roles as board members and to make sure that we understand what the CHA is doing to the point that we can stand up and be advocates effectively in a public arena and to articulate the value proposition which CHA has developed to Asha's comments.
I want to chime in, and I totally agree with everything that is being said. It's important for us to keep this in front of us and probably do an update once in a while as a reminder, because we're in today's climate, we have got to have that elevator speech ready to answer questions that may be posed towards us. And I know there'll be a lot of people probably calling each one of us because they probably know who we are. And we got to be able to be ready and be armed. I don't want to use the word armed, but have the equipment and tools necessary to answer probably some tough questions. So I thank you for this.
I'd like to just add, great report. Appreciate you bringing that to us, Aaron, and certainly in my role as a county commissioner and having the opportunity to talk to I represent my fellow commissioners on this board. They have sent me here to do this. And so it provides a great deal of comfort to me when I'm questioned about the setup of the Health Alliance, and I'm very proud of the fact that we are unique amongst most of the health organizations in the state. But because of the board that we have in place here, it is very easy for me to say we have an extremely well qualified, engaged, and involved board that is overseeing the activities of the Cabarrus Health Alliance, and I have total confidence in their decision making and the direction that they're leading the board. So that's a huge help to me when I'm speaking either to the public or to my fellow board members. So thank you all for your service. And certainly, I think everybody on this board recognizes how fortunate we are to have the professionalism amongst our staff that we do. So, this is a real feel-good thing. So thank you for bringing it to us.
I just want to add that thank you everybody for these comments. I feel extremely humbled to be a part of this group and especially to be leading the board now. And I'm terrified, but anyway, but I think that, a year ago, I was standing in the garage at the Cabarrus County Fairgrounds. Again, the county, we pull all these things in. And this county just comes together, and I'm standing in the garage looking around, and there's members of the public, members of the health board, and there's school nurses, and there's, doctors from the Health Alliance, and there's our leaders from the Health Alliance, and then there's all our staff from the Health Alliance are out in a garage giving vaccines in the middle of a pandemic. And I was just like, this is an amazing group, and it just has borne out, through this pandemic. And now I think that I'm just I'd like to take a moment to, during this lull, we're still in the middle of a pandemic, as Aaron said, but during this lull, this break for a moment, just to take a deep breath and to thank everybody for your work so far. And I think that, as we move into this resiliency phase and the recovery phase, that, I want to assure everyone that I'm going to do my part and do whatever I can to help our leadership here and all of our teammates here do what we need to do to take care of ourselves and to take care, so we can take care of the whole community. So, that's we have to take care of each other, and I want to give you my commitment to do that, and so we can take care of this great community. And I thank everybody for your role, and I thank everybody for being willing to come here every month or two and give your time. So thank you, Bonnie, and your whole team.
Thank you to everybody.
Well, okay, I didn't cry. That was good. So now we're going to move to announcements. Any announcements? Okay. There being none, I would just like to say the next board meeting will be Tuesday, May 17th, the third Tuesday of May. We look forward to seeing everyone there. And I'm going to entertain a motion to adjourn after an hour. That went long, an hour, it wasn't too bad here. It was an hour and 40 minutes. Okay, motion to adjourn.
So moved, Mark.
Mark Spitzer, second.
Second.
Dan Hagler, I can count on you.
It wasn't me. It wasn't me, but I'll take credit for it.
It was me, Daryl.
Oh, Daryl, oh, you're big. Oh, no.
It's about the
Okay,
only
here we
thing
go.
I've accomplished so far.
Cecilia Plez,
Aye.
Kim Daylor,
Aye.
Asha Rodriguez,
Aye.
Mark Spitzer,
Aye.
Daryl Adams,
Aye.
Dan Hagler,
Aye.
Steve Morris,
Aye.
and myself, Laura Ponso, will adjourn the meeting.